To kick off, thank you, Zoom, for telling me the recording's in progress. But to kick off today's event, we have a special welcome from our state librarian, Wendy Knapp, who's actually on vacation. So thank you so much, Wendy, for giving of your time today and being willing to welcome us to this event. Wendy, take it away.
Thanks so much, Evan. And thanks everybody for being here today. I am so proud of all the work that's been done for the Ohio Digital Network. It's been a great growth this last year with the many metadata grants and the increase in images on BPLA. It's all been very exciting, and I'm even more pleased that the State Library of Ohio Board approved an ARPA grant, the American Rescue Plan Act grant, that is going to let us reinvigorate some of the DigiHubs, and I'm very, very excited about that. So I think there are a lot of DigiHub staff on the line, so shout out to all of you. We're about to make you super busy. So I think that's everything. Evan, I'll go ahead and turn it back over to you, and when I run out of battery, I'm lost. So hope everyone has a wonderful day today.
Thank you so much, Wendy, coming to us live from the rolling hills of Virginia. We appreciate that. I think that I am turning this over to, is it Penelope at this point or Jen? I've lost my cue sheet, I'm sorry.
It's me, Evan.
All right, Penelope Shumaker, please take us away.
Welcome again, everyone. We're going to start the day off with a panel about learning from our past and historical international health crises. As many of us work to curate collections based on our real-time experience with the COVID-19 pandemic and examine how it's affected the use and context of our existing collection, we want to look back at some similar events in history. And today we have with us Polina, Ilieva from the University of California, San Francisco. Polina is the Associate University Librarian for Collections, the UCSF Archivist and Assistant Professor with the Department of Humanities and Social Sciences at the University of California, San Francisco. Polina serves as PI for several collaborative multi-institutional grant projects funded by the National Archives, National Endowment for the Humanities, National Library of Medicine that support expansion and digitization of holdings related to the history of the HIV and AIDS pandemic and women scientists. Polina actively works with community health organizations in California on issues related to records preservation and establishing UCSF archives as a trusted repository for diverse community and research holdings with the goal of creating more inclusive and equitable historical records. We're very excited to hear from her. In addition, we're hearing from Dr. J. Alexander Navarro. He's the Assistant Director for the Center of the History of Medicine at the University of Michigan. Dr. Navarro received his Bachelor of Arts in History with honors from Rutgers and his Doctor of Philosophy in History from the University of Michigan. A diplomatic and political and intellectual historian by training, Dr. Navarro has taught and conducted research on a wide range of topics, including U.S. Latin American history and the U.S. Southeast Asian relations, Western labor history, and 20th century urban history, race and racism, and the issue of national identity. Since joining for the Center for the History of Medicine in 2005, Dr. Navarro has focused much of his research on the historical, social, economic, and political ramifications of the 1918 and 2009 influenza pandemics. He was the co-principal investigator and lead researcher on the center's landmark study of the use of the non-pharmaceutical interventions in the 1918 and 1919 influenza pandemic, and on the center's qualitative examination of the school closures implemented during the 2009 H1N1 pandemic. He is also the co-editor-in-chief of the American Influenza Epidemic of the 1818 to 1919 Digital Encyclopedia, and responsible for researching and writing the site's essays detailing the 50 American U.S. cities during the deadly pandemic. We're going to start off from hearing from Polina. We are going to take any questions from the chat and save them for later. We'll answer all the questions at the end, but if you have some question, go ahead and drop it in the chat and we'll just go ahead and save it so you don't have to try to remember it for later. Welcome, Polina.
Thank you. Thank you for this introduction, Penelope. It's a pleasure to meet many of you and to see familiar faces. So please just give me a couple of seconds to share my screen. And I will start my presentation. Good morning, everyone. I'm grateful to the Ohio Digital Network Fest organizers for inviting me and for putting together an amazing program during this challenging time. My presentation is based on my work as head of special collections and institutional archivist for the past 10 years at the University of California, San Francisco. I also rely on the work of my predecessors at UCSF, colleagues from numerous archival repositories and museums, as well as people living with AIDS, community activists, healthcare providers, and researchers, and I'm grateful to all of them. First, a few words about University of California, San Francisco, UCSF. UCSF is among the oldest academic health centers in the Western United States, tracing its origins to 1864. It is the only UC campus devoted exclusively to health sciences, with 4 professional schools and a graduate division. The medicine of yesteryears was highly paternalistic, where a patient usually lacked a voice and knowledge about procedures, drugs, and potential consequences of their treatment. Many, in particular marginalized patients, were experimented on without consent, and even after consent forms became more widespread, we rarely hear from patients who know their stories. The archives of medical and health sciences institutions were reproducing this model, focusing on collecting materials from healthcare providers and researchers. This presentation focuses on an approach to collection development adopted by UCSF that generates holdings with the primary sources that facilitate creation of a historical narrative that incorporates all of those impacted: clinicians, researchers, patients, and community, and allows for the examination of all facets of healthcare: political, social, economic, cultural, and biomedical. This approach aims to address silences and gaps that exist in the healthcare narratives and remediate a long existing historical distortion that was highlighted by historian Roy Porter, who advocated for a departure from a physician-centered account of medical history and a need to develop an alternative history of medicine, largely written from the patient's point of view. However, even this new approach is not supposed to be binary. It must include community that is broadly understood to encompass family, friends, and others. I have been investigating these questions for several years and couldn't have imagined in my wildest dreams that a worldwide pandemic will engulf the globe, making my research applicable to a vast majority of archival institutions, since all of us are now documenting this ongoing public health crisis. The human immunodeficiency virus infection, acquired immunodeficiency syndrome, HIV/AIDS, is caused by the human immunodeficiency virus. The first description of a clinical case of AIDS was published in CDC's Morbidity and Mortality Weekly Report in 1981. The disease was first called gay-related immune deficiency, or GRID, but was renamed in 1982 as the Acquired Immunodeficiency Syndrome, or AIDS. The HIV virus was discovered in 1983. Currently, no known cure or vaccine exists. However, retroviral drugs significantly prolong the lifespan and quality of life of patients. According to UNAIDS, in 2020, there were 38 million people globally living with HIV. Since the start of the epidemic, around 79 million people have become infected with HIV. 36 million people have died from AIDS-related illnesses since the start of the epidemic. San Francisco was one of the urban centers in the US where the early cases of the mysterious deadly disease were documented. The first patient with Kaposi sarcoma was reported in the city in 1980. The UCSF AIDS History Project began in 1987 as a joint effort of historians, archivists, AIDS activists, healthcare providers, and others to secure historically significant resources of a response to the AIDS crisis. In 1989, a conference, AIDS and the Historian, was organized with the goal to produce documentary strategy and recommendations for issues related to AIDS that could benefit from historical inquiry, outlining the types of materials that should be collected, biomedical response to AIDS, federal AIDS prevention efforts, social and biological origins, community-based response, images of AIDS, and so on. The decisions the archivists make in appraisal and collection development impact what kind of primary sources will be available for researchers. The UCSF archives determined in the case of the AIDS History Project to actively solicit papers from people living with AIDS and patient advocates, clinicians, healthcare workers, and researchers, social scientists, journalists, and science writers, community-based organizations. When I started as archivist at UCSF, I have been referring to these people as AIDS patients, but I am grateful to Laureen Willenberg, and you see her picture on the left, who corrected me. Naming these people patients make them faceless sufferers, victims, someone, quote, who bears pain without complaint, end quote. These are people living with AIDS. We do focus our outreach to and partnerships with people with AIDS community, many of whom have been open about their status and advocate for new treatments and continued research. They do want their stories to be documented and preserved. We, archivists, are following in the footsteps of the research community that started with the consent to identify as collaborators people with AIDS who participate in drug and other trials, donate their biospecimen and enable breakthroughs. In recent years, these activists have been invited to present in scientific conferences, and this is where I often meet them. This is a very emotional work for me. And this year, we added the papers of an amazing woman and activist, Laureen Willenberg. AIDS History Project includes a handwritten diary that was kept by Bobby Campbell, and you see his picture on the right. He was a registered nurse, AIDS poster boy, and activist. He was one of the first and most public people with AIDS. He died of AIDS complications in 1984. There are numerous federal and local laws and regulations that protect privacy and confidentiality. Since they differ from state to state, I will stress that issues related to the access to these materials have to be reviewed and discussed in advance of outreach and collecting activities. The majority of records in our holdings constitute records from clinicians and healthcare workers. The patient notes, correspondence, and reports reflect the evolution of patient treatment, political advocacy, changes in healthcare practices and regulations. I will highlight just a few collections, in particular records or papers of Dr. Marcus Conant, who was a professor of dermatology at UCSF and had a large private practice. In April of 1981, he documented 2 local cases of Kaposi sarcoma in young, apparently healthy gay men. He was the founder of the Kaposi Sarcoma Research and Education Foundation, that later became the San Francisco AIDS Foundation. The first outpatient AIDS clinic in the world was opened on Ward 86 at San Francisco General Hospital in January of 1983. The inpatient ward, Ward 5B, opened a few months later. Doctors Paul Wolperding, Constant Wofsy, Donald Abrams, you see the 3 of them on the left, were the founding members of Ward 86. The AIDS epidemic created a new level of collaboration between clinicians and researchers, a combined clinical and laboratory model. And we do have papers from all 3 of them. We also recently acquired papers of Michael Gottlieb, one of the primary authors of Pneumocystis pneumonia in Los Angeles report that was published on June 5th of 1981 in CDC's Morbidity and Mortality Weekly Report that I already mentioned. He was also one of the founders of the American Foundation for AIDS Research, AMFAR. Researchers' lab notes, correspondence, and reports reflect how scientific and treatment discoveries were made. Scientific records come in multitude of formats and include data sets, raw data, handwritten and digital lab notebooks, survey results, equipment, prototypes, and the list goes on. Scholarly communications are happening now not only through officially established channels like journals, but through social media. That's why we collect other newer formats of scientific records. Lab websites, blogs of individual scientists, their tweets, and YouTube channels. On the right, you see a picture of Dr. Selma Dritz. Dr. Dritz played a seminal role in the early days of the AIDS epidemic in the city. As an assistant director of the Bureau of Disease Control, she tracked cases of AIDS, collaborated with Center for Disease Control and UCSF, in helping establish the etiology and epidemiology of the disease, and educated the gay and straight communities about AIDS recognition and prevention. Her papers were used by Rich McKay, a historian from Cambridge, in his research on so-called patient zero role in the AIDS epidemic. Through archival research and collaboration with Michael Worobey, an evolutionary biologist, they proved that Gaetan Dugas was wrongly accused to be the person who initiated the HIV spread in Northern America. On the left, you see a picture of Dr. Deborah and John Greenspan. John Greenspan is Director Emeritus of the AIDS Research Institute and is the founding director of the UCSF Oral AIDS Center and AIDS Specimen Bank. He and his longtime collaborator, Deborah Greenspan, have made major contributions to dentistry and HIV research and care. Other important components are papers of social scientists, journalists, and science writers. For example, papers of Nancy Stoller and Lori Garrett. Their research on social implications and effect of the epidemic on minorities in the US and around the world, interviews with different constituencies, helped recreate the unfolding of the crisis and its subsequent development. From the early days of the epidemic, activists began to create community-based organizations to deal with the needs of growing number of sick and dying, respond to the fear and grief of friends and loved ones, and serve as centers of compiling and disseminating information. Over time, a very effective collaboration of city and state agencies, hospitals, healthcare providers, political activists, and community-based organizations evolved and became known as the San Francisco model of AIDS care. An extensive array of services were developed. to help people from various communities affected by HIV. One of the primary objectives of the AIDS History Project is to capture this complex evolution and to also provide instructions in records management practices to the community organizations. We serve as repository of records from the San Francisco AIDS Foundation, Shanti Project, several Buyers Club, and many other organizations. We recently acquired papers of Father Rodney DeMartini, a Catholic priest from San Francisco who was also a vocal AIDS educator and lobbyist. The diaries and letters of yesteryears were replaced by weblogs, Twitter, Instagram, and Facebook, and we are reaching out to people living with AIDS who chronicle the experiences of living with that disease and also participating in clinical trials. They want their voices to be heard and their experiences known. Even if they make the experiences publicly accessible, following ethical and professional best practices, before we start collecting their social media records, we ask their permission, explaining the mission and goals of our collection. The vast majority of documentation on UCSF university programs and research institutes that archives collected in paper form in the past now is presented on the web. In many cases, it is presented exclusively online and no print copy is produced. We are capturing the websites of the university administration, schools, academic departments, hospitals that provide care, education, and are involved in AIDS-related research projects, such as Center for AIDS Prevention Studies and AIDS Research Institute. We are also augmenting records of organizations and manuscript collections with their sites and social media crawls, as well as collecting blogs and websites of AIDS-related conferences. We have been raising awareness about the research value of medical records, the need to preserve them and convert to formats that can be easily accessible and analyzed. As a HIPAA-covered entity, we do comply with regulations for health research set forth in the Health Insurance Portability and Accountability Act. To access all data, including sensitive and confidential data containing PHI, protected health information, researchers have to submit a request to an institutional review board indicating what they plan to do with the data and how they will protect the identity of individuals. I was encouraged to find reference to post-custodial archival approaches in the Open Science UNESCO recommendations that highlighted the importance of developing new participatory methods and validation techniques to incorporate and value inputs from social actors beyond the traditional scientific community, including through citizen science, crowdsource-based scientific project, citizen involvement in community-owned archival institutions, and other forms of participatory science, end quote. This may sound new to many institutional archives whose mission is to collect institutional records, but I would encourage all of us to look beyond the walls of our institutions and discover citizen scientist groups and other community groups that need our support and collaboration. Here are just a few examples that demonstrate diversity of uses for AIDS History Project materials. They were used in documentaries, TV programs, books, theater plays, and exhibits. For many years, undergraduate students in history of medicine from Stanford University used our materials for class research assignments. The UCSF Archives, in collaboration with San Francisco Public Library, GLBT Historical Society, was awarded a grant from the National Endowment for the Humanities. As a result, we digitized almost 200,000 pages that were posted on the California Digital Library portal, Calisphere. In the process, collections whose components have been placed in different archives for various reasons were digitally reunited, facilitating access for researchers outside of the Bay Area. The archives also received the California State Library grant that enabled the extraction of the unstructured textual data from more than 200,000 digitized pages using OCR and related software. The project team is preparing the text as a research-ready data set to be used for digital humanities and machine learning research inquiries into the history of HIV/AIDS epidemic. This data set is in the process of being deposited in Dryad, a data sharing repository. The physical and digital exhibits, They Were Us, the UCSF Community Early Response to AIDS, opened in 2020 and were included in the AIDS 2020 conference virtual program. We all know that a good research is product of good sources. While working on collection development and appraisal documentation, we were pursuing the goal of preserving not only medical or social aspects of the epidemic, but changes in cultural values, shifts in policy and social response. The archive strives to balance the need to protect privacy and confidentiality with the growing number of requests to access the AIDS History Project materials. The mission of the UCSF AIDS History Project has broadened from the initial goal of identifying, surveying, and describing at-risk records of educational and professional institutions, nonprofit and community-based organizations that emerged in San Francisco. It reflects now the needs of researchers and community to maintain a complete and all-inclusive AIDS history research collection where patients, activists, researchers, clinicians, journalists, and community organizations play an equal role in assuring the opportunity to preserve and re-examine the history, research, and use these materials in looking for new ways to respond to epidemics. In the past, the AIDS History Project collections were mostly used by scholars in humanities and community advocates. However, the new digitization efforts will allow us to convert currently hidden clinical and research data sets into data formats that can be analyzed using new computational methods, make them reusable, and allow scientists to repurpose them in novel ways. This collection remains the most heavily used at UCSF archives. Our efforts also created a snowballing effect. We do receive at least 1 to 2 offers a month for the donation of materials related to the AIDS epidemic. Thank you. I will respond to your questions at the end of both presentations, and as always, looking forward to comments and your ideas for collaborations. Thank you.
Thank you so much for sharing, Polina. And now we're going to hear from Dr. Alex Navarro.
Great, give me a second just to share my screen here. Okay, good morning, everyone. And I'll begin. I'll try and keep this somewhat short. I'm sure that many of you now have a much deeper background in the 1918-1919 pandemic than you would have just, say, 2 years ago or a year and a half ago, thanks to the COVID-19 pandemic. And the same page here. There were 4 waves of the pandemic. There was a spring wave that occurred late in spring of 1918. Researchers, we call this the Herald wave because it heralds what was to come. At the time, physicians and public health officials certainly took note of this because, as you know, most seasonal influenza outbreaks occur. They start in the late fall and they go through late winter to early spring. And this one occurred in the late spring. And so that made people stand up and take notice. It had a very high attack rate, so lots of people got sick, but it wasn't particularly deadly. It was perhaps slightly more deadly than seasonal influenza. And there had been in the years previous to this, 1915, 1916, some pretty bad influenza seasonal outbreaks. And so people didn't notice, researchers certainly noticed at the time, but the general population didn't really think much of this sort of bad spring influenza outbreak. Then, of course, right around the corner was the deadly second wave in 1918 in the fall. And so when we talk about the 1918 pandemic, we're really talking about that fall wave. And then what led into a third wave in the winter of 1918 into 1919. Now, there's some discussion about whether we should really call this a separate wave or not. I think you can look at it either way. Certainly there was a diminution of the epidemic in the late winter of 1918, and it picks up again starting in January of 1919. Some of that might be due to the use of social distancing measures. And so you really can consider it a continuation of the second wave, but because of the sort of separate little peak, researchers do like to differentiate between the two. And then, of course, it came back in 1920, in the winter of 1920, not nearly as bad. But if we had not had the fall and winter 1918, 1919 outbreaks, we would be talking about the deadly winter 1920 pandemic. It was bad, but because so many people had gotten sick and recovered, of course, there was a higher level of, we were approaching herd immunity by that time. After 1920, after the winter of 1920, this H1N1 strain continued to circulate for the better part of the 20th century until 1957, when a new strain caused a pandemic, and then again in 1968. And we know that these strains still circulate. The H1N1 strain still circulates today. It popped back up in 2009 with the swine flu outbreak. That deadly wave, that fall wave in 1918, first appeared in the military camps in places outside of New York City, Boston, and Philly, and naval stations, and then very quickly spread from late August into early September, very quickly spread into civilian populations. And it's important to note that, of course, this was a time of World War I, so we have mass mobilization of troops. We have troops going from camps and naval stations to naval ports for embarkation to go over to the European front. We have training detachments that are coming from various military camps, going into civilian populations in cities, usually at colleges and universities, for additional technical training. And we have civilians who are going into nearby military camps to bring supplies and food to the troops, to entertain the troops. When soldiers and sailors would go on leave, they would often go back home if they had enough time. If they didn't have enough time to make it back to home, they would often stay with a local family who would host them and have them over for dinner, that sort of thing. So very quickly, this pandemic spreads from really three main epicenters, Boston, Philly, and New York, almost simultaneously, and then spreads across the nation. You can see the map there of how quickly it spread. Within just a few weeks, it basically hits just about every community in the United States. We don't know for sure how many people died. The sort of semi-official Census Bureau estimate for the United States that came out in 1920 was that about 548,000 Americans died, but they realized even at the time that that was likely a very large undercount. Since that time, researchers have sort of added on, and first it was maybe 625,000, 650. Now we think maybe 675,000 Americans died. We're not quite sure, but that is certainly within the realm of possibility. And of course, COVID, we just recently, unfortunately, sort of beat that record. Again, worldwide, similarly, we don't really know how many people died. It's estimated about 20 to 50 million people worldwide. We believe that in India alone, as many as 8 million people died. So until the COVID pandemic, the 1918-1919 pandemic was the worst sort of public health crisis in modern times, and the one that we have the best historical record for. And of course, there were many similarities to today's COVID-19 pandemic, both in terms of the public health measures implemented, but also in terms of the pushback, especially from business owners in 1918, and in places where they implemented mask orders, particularly out west in states like California, lots of pushback from people who did not want to wear their masks, and also epidemic fatigue. So the ability, or really inability, for communities to re-implement some of these public health measures when they removed them too quickly and faced another resurgence of the disease. They met with a lot of pushback from people who were simply tired of the pandemic, and we see that today, of course. We don't have, even today, we don't really have definitive evidence of where this strain originated and why it was so deadly. there's been lots of work on the virology and sort of reconstructing the genomic sequence of the H5N1 1918 strain, and lots of theories about where it first originated. So what led to that spring herald wave? There is some strong evidence that it may have originated in Kansas in a military camp there. Other researchers say it likely came from China or Southeast Asia, where lots of influenza strains do originate. And there's also some evidence to suggest it may have come out of one of the military camps or the trenches in the European theater in France in particular. So we really don't know for sure. So at the Center for the History of Medicine, and this is when I joined the team there, we began studying the 1918 pandemic back in 2005. So this was under President Bush, and the fear then was H5N1 avian influenza. So for those of you who might recall this, it's still circulating in very small numbers. It's still a potential threat. It's a very deadly form of influenza found in chickens and waterfowl. And because of some of the wet markets in Southeast Asia, there was some transmission from these chickens to humans, and then very limited, it seemed to be human to human transmission, usually within the families of people who were working in these markets. It's had a 30 to 40% mortality rate. So it was an incredibly deadly form of influenza. And so there was also this fear of bioterrorism because of 9/11 and the threat that terrorist organizations could start moving towards using biological agents as a weapon. And so we got a call from a think tank called the Defense Threat Reduction Agency, which we had never heard of, inside the Department of Defense. And the DTRA, the Defense Department, and this Defense Threat Reduction Agency wanted to know, there had been some, what we thought at first may have been some urban legends really of communities that somehow managed to escape influenza by closing off their borders, or even sub-communities that may have done this in military installations. And so the government wanted to know, would it be possible in the event of another outbreak of a deadly respiratory disease that looked like it might become epidemic or even pandemic, could they load military assets onto ships and send those ships out to sea in order to protect military personnel? And so they asked us to look at these, what we called provisional escape communities, places that did not seem to get influenza. And what did they do in order to dodge that bullet and avoid that? And could that inform public health policy? So we uncovered about 7 provisional escape communities. There were undoubtedly others in the United States that were probably very small communities that maybe didn't have much natural interaction with the world outside, and therefore were a little bit more self-contained and managed to escape getting influenza. And we found some that were that did some pretty amazing things. Gunnison, Colorado, for example, both the town of Gunnison as well as the county of Gunnison closed off. The entire county closed off. They basically required everyone coming in on a train to go right to the county seat of Gunnison, the town, and they put them into quarantine at a local hotel. If you lived in the county, traveled outside, you came back, you had to go into immediate quarantine in your house. And if you were driving, they barricaded the roads with signs saying if you needed to drive into the county, you had to basically go right through the county and not stop. And they arrested people who broke that rule. They kept it in place for several months. On top of that, Colorado, the state of Colorado, had some social distancing measures that they implemented, like many states across the United States at the time. And so they were living with those social distancing restrictions as well. And as a result, only one person got sick. There was somebody who had traveled outside to Chicago. She came back, quarantined in her house. She passed it on to her sister. Her sister passed away. But those were the only 2 cases, and that only 1 death during the period when these restrictions were kept in place. As soon as they were lifted, of course, they got cases because you still had a naive population susceptible to the disease. Our project relied on a few secondary sources. There weren't many dealing with these escape communities, but many, many primary sources, mostly small local newspapers. We looked at special collections and archives. We looked at state archival collections and local historical society collections to dig out what we could. Now, on the heels of that, when we presented that information, that report to the Defense department. It caught the attention of the CDC, and in particular, a man by the name of Dr. Marty Citron, who's the director of the Division of Global Migration and Quarantine. He's at the CDC. He's basically the US's chief quarantine officer. And Marty came to us and he said, look, it's really fascinating about these escape communities, but it doesn't tell us a whole lot about what we might do in the event of another outbreak. You know, we can't close off. It wasn't really feasible in 1918 to close off a city, and it certainly isn't all that feasible to do it today, at least in the United States. And so Marty had some research questions. He said, you know, what did these cities do in terms of these non-pharmaceutical interventions, all right, the things that we call today social distancing measures? What did cities do in the fall of 1918? And were they effective? And can we prove or show that they were effective or ineffective? And if they were effective, could these NPI be used to buy time until the United States and other countries could develop an effective vaccine or drug therapy and then deploy that to as many people as possible? And Marty coined the term flattening the curve. This is something we're familiar with today. Could these NPI be used to help slow community transmission so that hospitals and healthcare systems were not overwhelmed? It wouldn't end the pandemic by themselves, but could we slow the transmission down enough that we could buy time to develop a vaccine and get shots into people's arms? And the way Marty explained it, he was thinking of this as slices of Swiss cheese. So none of these NPI in and of themselves were going to be 100% effective. We know that. Like Swiss cheese, they all have holes in them. But if you stack up enough slices in the right way, hopefully you get a stack where the holes don't go all the way through. And so if you use school closures, massing orders, ventilation orders, et cetera, hopefully you can get somewhere closer to 100% protection. It's not going to be 100%, but somewhere approaching that until you can get an effective vaccine that would add further protection. So we found this fascinating, and so we dove right into it. We selected 45 of the most populous US cities at the time, and we had to drop Atlanta and Detroit for lack of sufficient data. Atlanta was interesting. Atlanta just basically prematurely declared, the mayor said, epidemic's over. It wasn't, and stopped reporting data on cases and deaths. Detroit had a little bit of the opposite problem. Detroit had grown so quickly between the 1910 census and then the upcoming 1920 census that by 1918, the Census Bureau really didn't have an accurate estimate of how many people lived in Detroit, and they knew that. And so they removed Detroit from their calculations because they couldn't do, they didn't have that denominator of how many people lived in Detroit. And the key source really was the US Census Bureau's weekly health index. And if you're looking at these documents, a scan of documents, it's the one in the middle on the left there. And it was just a typewritten document. It was usually 2 pages. During the pandemic, it grew to 4 pages. And it was a list of how many people, or at least the estimate of how many people lived in the city. And then it was how many people died of all causes. And then they added these 2 sheets, one for influenza and one for pneumonia, getting those figures from the local and state health authorities. And so this was really the gold standard because there was one standardized set of data on how many people had influenza and pneumonia. And we had to combine those 2 because of the way that physicians would report cases and deaths. People died of influenza, but often died of pneumonia brought on by influenza. So some physicians reported that as influenza, others as pneumonia deaths. But now we had a standardized set of data. When we first found out about the weekly health index, we thought that this would be a very easy document to get. I was in Washington, D.C. at the time doing research for the project. And we discovered that there was this weekly health index out there. And so I thought, okay, I'll find it in one of the archives, National Archives, perhaps Library of Congress. It was nowhere to be found. We finally found a copy on microfilm at the Science, Industry, and Business Library at the New York Public Library. So I took a train up to New York, got a copy, and came back. And so it was sort of like handling some secret documents that I didn't want to lose because it was so hard to find. We also selected 2 newspapers for each city. We tried to select wherever possible the 2 highest circulating newspapers for each of the cities in our study. And we went through day by day, reel by reel, capturing any and all mentions of influenza. Typically, they would have been front page news for most of the pandemic. As the pandemic wore on and as things started to improve somewhat, you'd see these stories buried deeper and deeper in the newspapers. So that was pretty painstaking work that we had. I did that. We had lots of other researchers going through these reels. We also tried to capture the state and municipal health reports for each city from the period of 1917 to 1920. So we wanted to get a sense before the pandemic of the underlying health conditions, generally speaking, in these cities, as well as during the pandemic. Again, like the weekly health index, we thought that these would be easy to find. They were very difficult to find. Some libraries have been very good about keeping full sets of this data and these documents. Others over the years have had sets have been damaged by flood or fire, they've been lost, or they've just been tossed because they weren't really used. And of course, as we all know, libraries and archives, space is a premium, and so they always have to make decisions about what documents to keep. We finally found most of them at the New York Academy of Medicine. They had thrown them, most of them, in some boxes and stored them in the offsite warehouse, and so we finally prevailed upon them to digitize and grab as many as they could and send them to us. We tried to track down as many as possible the federal and military reports on influenza, especially for the Army and the Navy. The Navy has a very good report on influenza at the time. And we traveled to over 130 different institutions and to collect as many archival documents as we could. Of course, National Archives and Records Administration was critically important. We also went to state and municipal archives, lots of university repositories, historical societies, and whatever other special collections had information that we could use. And we didn't capture all by any means, but we tried to capture as many of the contemporary medical and public health journal articles as we could, so we can get an idea of what their understanding in 1918 was of influenza, how it spread, how it killed people so quickly. We then abstracted all of these documents, paying special attention to these non-pharmaceutical interventions that were used, when they were implemented, when they were removed, how difficult it was to implement them, et cetera. And working with the CDC and some statisticians, we concluded that the early, layered, and sustained use of these NPI was associated with both lower peak as well as overall excess mortality. So in short, NPI in 1918 worked. We published the results in August of 2007 in JAMA, and there's a citation there if anyone is interested. We're very proud of our work. It was a pretty groundbreaking study. And Marty Citron at CDC at the time was drafting this interim pre-pandemic planning guidance document for the Department of Health and Human Services and the CDC. And based on our conclusions, as well as a few other groups that were working on similar studies at the time, who came up with similar conclusions, Marty wrote those into this interim pre-pandemic planning guidance. Basically, in the event of another respiratory disease pandemic, state and local communities should strongly consider the use of non-pharmaceutical interventions in order to slow the transmission and to flatten the curve and buy time. That document then sat on basically on a shelf, if you will, for 13, 14 years until March of 2020, when of course we all saw across the United States communities starting to implement closure orders. In some ways, much more strictly than they did in 1918 even. So that's the quantitative side, but we had all this qualitative data that we had discovered. So in addition to what cities did and when they implemented these NPI and took them off, what about the qualitative findings? So how did each city grapple with its epidemic in a day-to-day way? How did they marshal resources? What kind of organizations helped out, the American Red Cross and other civic and charitable organizations? Was there political pushback? We found that there was in many cases. Newark, New Jersey is a prime example of that, where the mayor basically took on the state health department and who got to call conditions epidemic and what kind of closure orders were necessary. In short, what did we do with this mountain of documents that we had collected? And so initially we thought, well, maybe we'll try and publish some sort of encyclopedia. This was, for us at least, the early days of digital projects. And so we weren't really thinking, we're still thinking as historians, still thinking of print. And then we realized, no publisher is going to want to touch that. That's just not going to sell. And at the time, M Library and M Publishing at the University of Michigan was trying to expand their digital portfolio. And so they came to us and they said, look, I think we could help out here. We can put this online for you, make it we'll take over and ensure that this will always exist, and we'll transition it whenever necessary to new technology. And so we can make this accessible to as many people as possible. And so that's when we embarked on this influenzaarchive.org project. We expanded the list of cities to 50 to get some more regional representation, and to include some of the cities like Atlanta and Detroit that we'd had to cut earlier. We conducted lots of additional research. We wrote these detailed essays on the pandemic experience of each city, which are sort of the most popular part of the website. Lots of people like to click on the essays there and see what their local city experienced in 1918. We digitized and uploaded every document that we collected. In fact, one person at M Publishing did this by herself. We helped sort of create the workflow to get that information to her, but she painstakingly digitized every single document, tens of thousands of pages of documents that were not originally gathered with the intent of making them accessible online. And so you can imagine taking old microfilm reels of newspapers that we then printed out copies and then had to scan those copies as opposed to doing it digitally from the get-go. The site was launched in October of 2012, and initially, traffic was a few thousand users per month, and we were thrilled with that. We would get emails from school teachers in particular saying that it was a wonderful resource for their students and their classes. And that's sort of where it was for the better part of a decade and a half or so. And then, of course, with the pandemic, COVID-19 pandemic, suddenly site traffic jumped to several thousand users per month during the height of the pandemic. I won't spend too much time on this. This is just a little bit of the workflow that we went through. I'm trained as a historian with no special training in digital archives at all. So some of this I oversaw, but it was sort of beyond it's not really in my wheelhouse. But as I said, we created detailed abstracts of each document. This was critical not only for our own work, but because the OCR that we performed on the scans was not cleaned. It was that would have been too work intensive. And so the abstracts really helped us develop the list of keywords that we continued to refine as we went through the process. We entered each document into a database using the Dublin Core metadata element set as a template that we then customized a little bit. And Library then imported that database into their platform along with these Dublin Core HTML elements. As I said, all the documents were scanned and had their page images were OCR'd. And then we had a web designer create that front end. And M Library then tied this to their DLXS backend so that you could use the front end to navigate to the documents, but you can also use it to navigate to the city essays. In terms of site navigation, the essays can be selected right from the homepage, and most of the cities also have these event timelines. So we had their epidemic curves along with a calendar at the bottom, and then you could sort of click on key dates about when things happened, when the NPI were turned on, when they were turned off, when there was a major meeting, for example, of the Board of Health and what the outcomes were there. The site is fully searchable using basic Boolean proximity and bibliographic searches. There's also a browse function for those people who just want to peruse the site but don't really know exactly what they're looking for. So you can browse by title and cities and organizations, et cetera. And we have a very small image gallery with some captions. It wasn't our intent initially to have any images, but along the way we did capture some. We hope to capture more in the future. I know that over the past year and a half, I've gotten lots of media inquiries and I've done lots of interviews about comparing and contrasting the 1918 pandemic with today's COVID-19 pandemic. And I'm always asked, do you have any images? And unfortunately, we don't have a ton. There are many, many, many more out there. It just wasn't our part of our original project to capture images. And so we hope to add more. What is the future of this archive? Because one of the great things about having it online is that it can grow and it can expand, and we can add to it whenever we need to. So we do hope to gather additional documents to add to the collection. We have some, I have them in my office back on campus. I have some additional information that was sort of tangential to the main thrust of our collection that was not scanned originally. And so the hope is that eventually we will be able to scan those documents and add that as well. In recent years, we've added some more military reports that we've discovered. We hope to bolster the image gallery. We're especially interested in this documentation on the individual experiences. Unfortunately, most of what we have is really a sort of a top-down look. And we hope to migrate the platform from DLXS, which is the mLibrary's very old platform, which it's getting a little bit long in the tooth, to a new platform they're using, Fulcrum now. And we hope that we can improve site navigation in the future. That's all I have, and I'll be happy to take any questions when we get to that point. So thank you.
Thanks, Alex. We do have a few questions that have come in. We'll start with one for Polina. Did you know of any problems that early collectors in the archives had in getting people to donate documents? Is it hard to get people to talk about such life-changing events in the moment as they're happening? Or did most of the collecting happen at UCSF, I'm sorry, after the 1980s?
Yeah, I do keep in touch with some of the team members who were founders of the AIDS History Project, including Robin Chandler. Some of you may know her through her work at Society of American Archivists. And yes, so our predecessors, archivists, have spent a lot of time educating community, activists, even researchers and healthcare providers on the value of these documents and the need for preserving and providing access to them. And it takes time, and you know, that's an ongoing process. And our predecessors also, one of the projects that they did was to survey organizations, nonprofit organizations that emerged, and then provide training on records management. Because we kind of started with that post-custodial approach before it emerged as such an approach. And the first step was educating about records management and the need to preserve materials, because some of the nonprofits and community organizations, they emerged, and then, you know, as the need was subsiding, or the city or state was taking on responsibilities, they were folding out, and so it was the need existed to educate them and work with them, collaborate with them in order to preserve this material so they can be useful by future historians like Alex in making, in researching, investigating the history of the AIDS epidemic. And as I mentioned, that process continues, and quite often it takes, you know, maybe even several years to convince someone to preserve their materials, or we just continue working with some of the organizations, helping them to organize their records and keep the records with community instead of giving them to UCSF.
Thank you. We have a question for Alex about, was there anything you would have done that would help you be more prepared for the influx of attention and requests that you've had in the past 18 months?
That's a good question. So in terms of the archival materials, I think if we could have gone back and done it over, we would have tried to, as limited as the technology was, not that long ago even, I think we would have tried to collect as much of the materials we did digitally to begin with, or at least with an understanding that we were going to digitize this, so that we wouldn't have sort of copies of copies of copies that we then put online. Lots of the media requests I would get were, I've read this article that was on your, a newspaper article, for example, from 1918 that was on your website, but I can't read parts of it. Do you have a cleaner copy? And, unfortunately, the answer is no. Now, some of that information I was able to glean by going back to the paper copy and maybe reading it slightly clearer. So I think if I had a Wayback Machine, I would go back and with the understanding that we were going to create a digital archive out of this. That wasn't our original intent. It was originally a study we did for the CDC to help inform public policy. And I'm glad we were able to create that influenzaarchive.org website as a result. But in some ways, because it was a little bit of an afterthought, it has some limitations.
Sure, that's understandable. Even as many archivists I've talked to, how much the technology has even changed in scans and things that we have in our archive. It's greatly changed. Unfortunately, we're already at 11:01. We really appreciate both of you sharing with us today. Thank you so much for coming and speaking with us. You're welcome to stay for the rest of the day, and we'll be sharing this presentation. We are going to take a 15-minute break, 14-minute break, and come back at 11:15 for everyone else. Thank you.